Hello and welcome to the latest edition of Practo Connect webinar. My name is Dr. Nilesh Bhandari and I head Doctor Relations at Practo. We have been living with the coronavirus for almost 1.5 years now. All of us rejoiced early this year when the cases dropped, lockdowns were lifted, and vaccination was started. But the easing of the lockdown saw many people almost forget to maintain social distancing and sanitize their hands. This led to the rise of the second wave of COVID-19 cases, which was probably much worse than the first wave. New cases increased by over 400%, and so did COVID-associated deaths. Many of the clinical features in the second wave were different. New organ systems were involved. It was estimated that the infection transmission was slightly higher than the first wave. New variants of concern emerged, notably the Delta variant, which was first seen in India. COVID-associated fungal infections were also seen for the first time. To help us make sense of the second wave, manage the complications of the second wave better, and prepare us for the upcoming third wave, we have with us two eminent specialists. Our first speaker is Dr. Ajay Handa. Dr. Ajay is a noted pulmonologist and critical care specialist. He has been an MCI recognized professor for MD Medicine and DNB Medicine from 2010 and has mentored many students in this period. He has served in many armed forces hospitals over 3 decades, and his last assignment prior to joining Sakra World, where he is right now, Sakra World Hospital, was as senior consultant and head of internal medicine and pulmonary medicine at Institute of Naval Medicine, Mumbai. Today, he will be talking about what clinicians can learn from the second wave and how they can be better prepared for the third wave. Also with us is Dr. E.V. Raman. Sir, Dr. Raman is an established ENT specialist and a leading head and neck surgeon in Bangalore, currently at Manipal Hospitals. He is also the chief architect of Center for Otitis Media Research and Education, CORE, which aims at spreading awareness amongst people pertaining to possible causes and treatment of infections of the middle ear. Dr. Raman sir will be talking about the most feared complication of COVID seen during the second wave, namely the black fungus or mucormycosis. Last but not the least, I would like to add that both the speakers are my seniors from our college, Armed Forces Medical College, which makes this webinar very special for me. Hearty welcome to you, sirs.
Thank you.
Thank you. Also, for the audience, if you have any questions, please put them in the chat, and we will be taking these questions at the end of the webinar, and we will answer them towards the end. So over to you, Dr. Ajay sir, please.
Thank you, Nilesh, and I'll start the share screen now.
Yes.
1 second. Is the slide visible?
Yes, sir.
And am I audible to, I think I'm audible to you, so I'm audible to the entire audience. So good afternoon, all the colleagues and friends who have joined us for this afternoon's learning session on COVID-19. What are our learnings from the second wave and what is the way forward? COVID is a disease which has come in December 2020, and we are, still learning a lot about it. Medical literature on COVID subject is booming. If you just enter COVID-19, you get 1.5 lakh articles on PubMed. And though we have been handling this disease for the last 1.5 years, we are still learning about various facets of this disease. And we'll share what information is there today, because what's current today may not be the standard of care a few days from now. So this is the graphical representation of what Nilesh was trying to say. The first wave was seen somewhere around August, September, and we had a peak of cases which went to about 1 lakh of cases, or 90,000 odd cases. And we had a downslope of the cases, and thereafter we were slightly careless in our activities, and we had a hit with a huge amount of cases, almost 4,14,000 cases, which was at the peak of the pandemic. And you can see the difference between the first peak and the second peak. where is 1 lakh and where is 4.5 lakh, and accordingly we had severe amount of severe cases as well as lots of mortality. And the last part of the graph heads downwards, thankfully at the present moment because of the effect of the lockdown. But we must continue our efforts and COVID appropriate behavior, because the second wave is forecast somewhere around October, November. But if we are not responsible, it may hit us, and minor waves may happen even prior to that. So was the second wave different? Yes, as clinicians working in the hospitals, we feel that the age group of the population which we treated was largely younger. We had patients in 30s and 20s. These were the unvaccinated population, and majority of them are the breadwinners for their family who were engaged in economic activities and outdoor activities, hence greater exposure. We saw a larger number of pregnant and lactating mothers. We saw children being involved more than the first wave, but thankfully their disease was much milder. The disease spectrum this time was more severe, and though there is a question mark on the mortality being considered officially, the figures are not tallying, but the mortality in our hospitals was definitely noted to be higher. This is a study from Spain where they had their second wave somewhere around October, both in the last year, March and October. They also found that the second wave was slightly different. They had more younger people, and that time, mind you, the vaccination was not yet started. They also found that it affects more of pregnant and postpartum and children. GI symptoms and renal involvement was noted to be more common. The treatment, the world had moved away from invasive mechanical ventilation after a lot of deaths happened in Italy and United States. Now, non-invasive mechanical ventilation was the mainstay. Steroids and anticoagulation are the predominant backbone of treatment. However, Spain found that the hospitalization was shorter and the mortality was lesser, which is different from what we experienced in our second wave. So was the virus different? Our genomic studies are limited, so we cannot really say with a great amount of authority, but whatever random sampling was carried out in states found that the variants which were there were different from the first wave. Punjab had almost 40 to 50% variant of the British strain, and Maharashtra had 60% or so of the mutant 617 strain. We all know that this variant was definitely more infectious, because if one member got the disease, all the family members got the infection. Whether they progressed on to clinical disease or not depended on the host factors, but vast majority of them did get the disease. Definitely it was more pathogenic because the disease was found to be more severe, and I shall describe why it was more severe. The clinical presentations were largely similar. I only want to highlight the difference in the features of fever and diarrhea. Fever in the first wave was a minuscule or a minor symptom lasting only for 1 to 3 days, whereas in the second wave, presence of fever was more prominent and it was lasting longer period of time, more than 7 to 10 days. Even people came with 2 weeks history of fever. Diarrhea was much more common in the second wave, almost to the tune of 50%. The cough, breathlessness, and chest discomfort were similar but more severe, and we saw the other non-specific symptoms involving the upper respiratory system as well. Now, the challenge in the diagnosis, because of the mutant strain, we had lots of false negative RT-PCR. As it is, the RT-PCR sensitivity depends upon the timing of the sample and the correctness of the sample and the processing in the laboratory. This time, possibly due to the mutant, we had much more common. It was found that false negatives were there. We were doing the test twice and sometimes thrice, especially in patients for whom we had a very strong clinical suspicion. Herein, HRCT was a very, very important diagnostic tool for taking therapeutic decisions in those clinical cases who were high suspicion of COVID. And if a patient had a CORADS 4 or 5, that is the radiological probability is high or very high, then we would go and start the therapy, because mind, the time is essence in a patient who is having COVID pneumonia. If the treatment is not instituted, the cytokine storm can actually kill the patient. And then came the term that it could be called as COVID-19 like syndrome that does not require PCR, and you could admit such patients who are hypoxemic to minimize their mortality and morbidity, and you could treat them later on. The PCR report was declared as not mandatory for hospitalization. COVID is truly a multisystem disease, involves almost every organ in the body. It is the direct cytopathic effect of the COVID virus directly infecting the lungs, followed by initiation of thrombotic vasculopathy involving almost all the blood vessels across the body. There's an endothelitis, and that causes a cytokine inflammation. The virus itself also causes a cytokine inflammation, and these cytokines then lead to the organ damage. Respiratory failure is the most prominent. Other organs which get affected commonly are the heart, the kidneys, the gut, and the CNS. I would like to just mention that there were a lot of cases who came with hyperglycemia or diabetic ketoacidosis, not being known diabetics from before, because COVID also directly affects the pancreatic beta cells, and they can come with de novo diabetes presenting with diabetic ketoacidosis for the first time. Now, going on to COVID pneumonia and its complications, the COVID pneumonia and the ARDS were more severe. This is definitely evidenced by the fact that higher number of patients needed high flow oxygen, so much so that there was oxygen shortage in the most important cities of India, and you had crisis reports coming out in the newspapers and the television. So that is a ample proof that the oxygen requirement was much higher than the first wave. So the disease was much more severe. Many of them required support. They progressed from severe pneumonia and hypoxemia to ARDS requiring non-invasive ventilatory support or mechanical ventilatory support, and we had a shortage of ICU beds, because when there is a 4 lakh cases, 5% of them require a huge amount of ICU beds. We also saw that patients with ARDS had spontaneous pneumomediastinum, that is rupture of alveoli leading to air leak in and around the mediastinum. I shall show you images, and this subgroup of patients tended to have a poor prognosis too. And this severe COVID pneumonia in this wave, who progressed on to developing hypoxemia, had a much higher mortality despite the standard therapy, and we shall talk about the standard therapy as compared to the first wave. This is a case in from our hospital where we treated this patient. He had this patient survived. He had a spontaneous pneumomediastinum around the great vessels. You can see this thin line of air around the mediastinum, and he also had significant COVID patches in both the lungs with extensive COVID pneumonia and ARDS, and this is the air around the heart. And the only problem is this pneumomediastinum can be a indicator that the patient can develop a pneumothorax and possibly even a tension pneumothorax if he is given positive pressure non-invasive ventilation or invasive mechanical ventilation. So one has to keep a close watch and do an ultrasound of the chest, and maybe even a drainage if there is a sudden clinical worsening in the setting of a tension pneumothorax. Also, in the second wave, it was found that pulmonary thrombosis inside the pulmonary arteries in the smaller vessels, and also pulmonary thromboembolism, where there is a deep vein thrombosis in the leg with embolism to the pulmonary circulation, was seen in almost 20 to 30% of cases. We, as a team, would consider CT pulmonary angiogram to prove the presence of pulmonary thrombosis if the patient had the high-risk clinical indicators, that is hemoptysis, sudden chest pain, unexplained worsening of hypoxemia, or highly elevated D-dimers, and we found that bilateral segmental or subsegmental pulmonary artery thrombosis was found to the tune of almost 30% in the second wave. We would resort to doing a bedside echocardiography with the help of our cardiology colleagues and leg venous Doppler with the help of radiology colleagues if the patient was too critical to shift for CT pulmonary angiogram, or if the patient had renal failure. And we would find that some patients had RA-RV dilatation with features of RV strain in those who had pulmonary embolism, or many of them we picked up the presence of deep venous thrombosis in the lower limb venous system. This is another interesting complication where this patient had severe COVID ARDS. As you can see, almost the entire lung is affected bilaterally. This is 18th of May. And when he had very high D-dimers, we did a pulmonary CT angiogram, and we found the posterior segmental artery of the right upper lobe had a clot which was detected in the CT pulmonary angiogram. And after discharge, when this patient came for us for his follow-up a month later, 3 days back, we found that he had a significant large thick-walled cavity in the right upper lobe in the same location. This is a pulmonary cavitating infarction. Because this patient has no fever, no cough, no sputum production. He has gained 6 kgs of weight, and he is doing well. But differential diagnosis of pulmonary tuberculosis and mucormycosis has to be entertained in this patient. We feel that he is a pulmonary cavitating infarct, and we have asked him to be on follow-up. If he develops fever and or cough, hemoptysis, he is requested to come back for follow-up and a check bronchoscopy. Cardiac involvement would be seen in the form of myocarditis or cardiomyopathy, where the patient may be in frank cardiogenic shock or may present with left heart failure. There were many cases who had ST elevation myocardial infarction requiring thrombolysis, a few of them requiring revascularization. There could be de novo atrial fibrillation, or some patients had sudden death due to ventricular tachycardia, ventricular fibrillation. AKI with hyperkalemia and oliguric renal failure has been a condition which has responded well to standard treatment. In fact, we have not withheld remdesivir. We have given them remdesivir along with steroids and dialysis, and they have responded well to treatment, and most of them have recovered after treatment, and thanks to our nephrology colleagues for this. Neurological involvement in the form of strokes, which can be ischemic more commonly than hemorrhagic stroke. Encephalopathy, as I mentioned, try to rule out metabolic insult like a diabetic ketoacidosis or a hyperglycemic non-ketotic coma, and otherwise it could be a pure COVID encephalopathy with a meningoencephalitis. Syncope and pre-syncope are not very common, but they can be seen because of autonomic dysfunction related hypotension. We have also seen a few cases of COVID-related Guillain-Barré syndrome. Now, coming to the important aspect of treatment, what are treatment options at present? The treatment options are the standard treatment options, that is a steroid, methylprednisolone or dexamethasone, enoxaparin or heparin, and remdesivir with oxygen supplementation to maintain a saturation of about 94 to 95. It is important to start the treatment without delay at the time of admission. So we have kept written protocols in the wards, and in fact, we WhatsApp the treatment protocols to the wards as and when a new case is admitted, tailor-made to that particular patient. And it's important to detect when to start. So if a patient is tachypneic with or without early hypoxemia, that is the best time to start. This is the period when the patient's hypoxemic injury has not set in and it's early COVID pneumonia. So I would recommend that this is the best phase to start therapy, because they reverse quickly and don't go on to oxygen requiring respiratory failure or mechanical ventilation. Now, the three most important drugs, the most important one being the steroid, which definitely reduces mortality as per the recovery trial. We have used methylprednisolone. However, most of our other hospitals and colleagues are also using dexamethasone in equivalent doses. The duration is about 10 to 14 days. Remdesivir, often malign drug, used in probably misused also, and hence having a controversial status. Trials to support the use of remdesivir are there. It is useful in the hypoxemic disease or a multi-organ COVID with mild hypoxemia. It being an antiviral does not have much of a role if the illness is beyond the phase of 10 days where the viral replication is already ceased. Use of remdesivir should be carefully done in patients who have underlying liver dysfunction, because it is hepatotoxic, and if they have a presence of underlying QT prolongation more than 0.42, because that itself can prolong the QT interval further and predispose to ventricular arrhythmias. Now, anticoagulation is important, but it's important to use prophylactic anticoagulation in vast majority of patients, because as I said, there is a thrombotic vasculopathy in the pulmonary and other systemic arterial circulation. You would like, and venous circulation as well. You would like to use it in those who are having a proven DVT or pulmonary embolism in the full therapeutic dose, 1 milligram per kg twice in a day, enoxaparin. Steroids are indeed lifesavers. We have strong recommendations for use of steroid in those who are moderate to severe. Very simple to remember. Anybody who is hypoxemic is moderate. Anybody who has a high oxygen requirement or requires a high flow nasal cannula or NIV is critical. So it can be used in patients who are moderate to severe or critical disease. Should not be used in mild disease because it can enhance viral replication and do more harm than good. The benefit in recovery trial is those on oxygen supplementation and those on mechanical ventilation, and not in those requiring no support. The duration is to be kept at 10 to 14 days, followed by continuation only on requirement of, suppose like the patient has got post-COVID organizing pneumonia or some other condition where he requires to be used. Otherwise, for the common garden cases, you would use it for about 10 days. And its aim is to blunt the inflammatory cytokine mediated organ damage, especially in the lungs. Anti-cytokine therapy, again with injection tocilizumab being available, should be used only with great caution because it's a very potent immunosuppressive agent only in severe COVID who have not responded after adequate steroid trial, that is 24 to 48 hours, and hypoxemia is still showing worsening. There should be evidence of inflammatory markers being elevated, that is CRP more than 75, IL-6 more than 10 times the lower limit of normal, and there should be no clinical or biochemical evidence of sepsis. So we would look at total leukocyte count, we would look at procalcitonin less than 0.5, and a relative contraindication being the presence of HIV infection. Watch out after tocilizumab because there is a profound immunosuppression. There could be an enhanced chance of bacterial and fungal sepsis. So empirical antibiotics, if the clinical deterioration, send cultures and then culture directed therapy to tackle the infection. Another word of caution is after tocilizumab, the methylprednisolone dose or dexamethasone dose should be reduced. Mode of oxygen supplementation would rely largely on using face mask. Anybody requiring more than 8 to 10 liters would be given a non-rebreathing mask because it can provide FiO2 of 60 to 80%. High flow nasal cannula system is a useful tool which can be used in a patient who has a high oxygen requirement but not a very increased work of breathing. Increased work of breathing is evidenced by presence of tachypnea, that is respiratory rate more than 35, or accessory muscle use, that is sternomastoids and other respiratory muscles are active. But the only caveat about high flow nasal cannula and why it went into hibernation in the second wave was that it's a device which consumes high oxygen requirement to the tune of 40 to 60 liters per minute, and the consensus in our hospital was to avoid the use, and across the nation was to avoid the use of high flow nasal cannula and switch to non-invasive ventilation to conserve oxygen for the treatment of patients, and larger benefit of the larger population who was getting sick and getting hospitalized. Here is the picture of a high flow nasal cannula. It's able to generate a small amount of PEEP, about 6 centimeters of water at 60 liters per minute and 4 centimeters of water at 40 liters per minute. Approximately the liters per minute, you have an idea that it is about that much it is generating. So that's how it works. A non-invasive ventilation, which is the backbone of therapy, is delivered by an oronasal mask, and it is able to deliver much higher levels of positive and expiratory pressure, and also reduces the work of breathing by giving inspiratory support as well. So the non-invasive ventilation is the main ventilatory modality of support in the COVID pandemic, not only in our country, but across the world, because lessons learned from the first part of the pandemic when it started in USA and Italy was that early intubation and mechanical ventilation was leading to sudden deterioration and a very high mortality. So NIV has been preferred over invasive mechanical ventilation by and large, especially if the patient is showing stabilization and the work of breathing is better. That is, the respiratory rates are settling down and oxygenation is maintained. An advantage of non-invasive ventilation is that it can be delivered intermittently with the patient being taken off the NIV because it is delivered by a mask which is strapped to the face. It can be taken off and the patient kept on high flow oxygen with non-rebreathing mask to allow feeding and speaking, which is a great thing for a patient who is going through an illness, because COVID ARDS requires a long time of support. It may take sometimes up to 3 weeks, and it is quite common to find a patient who is very comfortable when the patient's toxemia is lesser. The patient is very comfortable, and this is quite a common sight. The patient is texting and looking at the thing from his relatives and trying to see and keep his mind distracted, and making a slow recovery in the intensive care unit. Invasive mechanical ventilation has its role if a person has got life-threatening hypoxemia and the work of breathing is unacceptably high, that is respiratory rates more than 45 are sustained after having given non-invasive ventilation for a couple of hours, and the patient has got saturations in the range of 60. Mind you, it is very common to find such critical patients having saturations of 50s and 60s on 100% oxygen, and the patient has the biggest thing is if they are uncooperative with the non-invasive ventilation, the asynchronous breathing can lead to aggravation of the lung damage because of just barotrauma. And these patients who are not ventilating, who are not washing out their carbon dioxide, and who are having critical hypoxemia, PO2 dropping to less than 45, would require elective intubation. Otherwise they will crash and die with a cardiorespiratory arrest. It's important to stress that early treatment reduces mortality, and there is a very important role of telehealth monitoring of patients who are with COVID, because everybody cannot be hospitalized, though many would like to come into the hospital and be in the safety. You like to give this message to each and every patient that self-monitoring of health status is crucial, because they have to come to the hospital at the right time. So I have given out these alarm symptoms: development of hemoptysis, sudden chest pain, breathlessness which is severe, and altered sensorium indicate that the patient needs to come to hospital immediately. If the person is stable, he has to monitor his oxygen saturation 4 times in a day. Hospitalization is indicated if the saturation, which was 97, 98, is now coming in the range of 94 or below, not when the patient. It's common to find patients come to the emergency with saturation of 76 and 75. Another important thing is to stress that the magical figure is 94 or below, and they should come as and when the oxygen saturation is showing a trend of decline. An important tool to unmask hypoxemia is a 6-minute walk test, which can be done in the safety of the home with a pulse oximeter anytime the patient feels breathless or after the 5th day. And if we do a 6-minute walk test, hospitalization is indicated if the absolute value of saturation drops below 94, or if the drop is by more than equal to 4%. So these are very important things, and these are taken from the national guidelines which have been published on the Ministry of Health and Family Welfare website in May. Post-COVID complications affect all organs. Let's focus on post-COVID lung fibrosis. Most of the patients who require prolonged non-invasive ventilation and mechanical ventilation, usually beyond 2 weeks, have areas of lung fibrosis. They may need supplemental oxygen for 2 to 4 weeks. For the risk of increased bacterial and fungal infections, we encourage them to be discharged to home on home oxygen supplementation with oxygen concentrator, keeping them on very minimal doses of oral corticosteroids if required, and antifibrotic as perfenidone. We have an important role for the physiotherapy people who explain the role of pulmonary rehabilitation exercises, and the vast majority of them show a good recovery over 3 to 6 weeks. Another important complication would be the development of post-discharge pulmonary embolism. We have seen patients who have come after 6 weeks with massive pulmonary embolism, acute myocardial infarction, and stroke. So there is a role of giving post-discharge anticoagulation to the patients who had severe COVID for about 4 weeks, and antiplatelets post-discharge for about 6 to 8 weeks. Bacterial infections, as I mentioned, can be in the immediate post-discharge period or even later. Fungal infections is a topic by itself, and we have an eminent speaker following me who will be covering the fungal infections in the setting of COVID-19. Our data from the second wave has shown we had about 2,150 cases, out of which 405 were in the ICU. We had a massive amount of deaths in the second wave, almost 251. Average mortality as compared to the first wave was 11% as against 6%. But a lot of patients were saved and sent home. Coming to the last part of my talk, what is the way forward? I think for COVID-19, prevention is much, much better than cure. So lessons for the people: we need to stick to COVID appropriate behavior till the pandemic ends. Pandemic is not going to end anytime soon. So we need to continue with our COVID appropriate behavior till the pandemic ends, and the government will come out with official statement when they say that moving with mask, without mask is safe. So till that time, masking, ensuring the safety of self and others is paramount. Maintaining distance from others of 6 feet. That means avoiding large gatherings such as marriages and religious events, which are super spreader events, and frequent hand hygiene. The three tenets of COVID appropriate behavior are very, very important. Now, vaccination is very important for controlling the pandemic, and this is data from CMC Vellore. They have 10,000 employees. They vaccinated almost 9,000 employees from the time the vaccination started till end of April. Those who were vaccinated with both doses, about 7,000 cases, it was found that there is a reduced incidence of infection by 65%. 35% do get infected. Vaccination cannot prevent infection because the mutant strain can cause infection, but the infection will be mild because the need for hospitalization was reduced by 77%. Look at the last two lines: need for oxygen reduced by 92%, reduced need for ICU admission by 94%. Very important that if the illness is there, it will be very mild. You will not require oxygen. You will not require an ICU hospitalization. So must take the vaccine. I implore all the healthcare workers who have not taken the vaccine to take it tomorrow. And the vaccines prevent severe COVID, and we have seen that vaccines save lives. Now, the lesson for the pandemic control is in the hands of the healthcare administrators. They have to expand the vaccination coverage, both with the availability of the other vaccines and the Indian vaccines and the upcoming vaccines from other countries like Russia and Novavax. We must ensure the coverage of about 70% of our population, which will be the only way that the pandemic will be blunted, and we won't see that tall Everest-like peak. We will see a small peak which will be able to be handled by the healthcare workers and the hospital infrastructure. If the vaccination is available and you have not taken it, it is your fault. Please take the vaccine. Encourage not only the family members, friends, other employees, your home staff, your people who work in your house, they should be encouraged. There's a huge concern about children. Thanks to the trials of Covaxin, the safety trials are going on. The results will be declared shortly, and then the children can also be vaccinated. Now the health administrators have to avoid the lack of oxygen by boosting up oxygen generation systems in all hospitals which have 100 beds or more, and government is facilitating the availability of loans to make it possible. Adequate supply of essential drugs so that we don't see articles that remdesivir wasn't being sold in black market. And I request the health administrators and the government officials and administrators and authorities to make sure that the safety of the healthcare workers is ensured, to keep the motivation, to keep their morale high. No, not good to see physical or verbal abuse after having put in so much of effort to save the lives of people suffering with serious form of illness. I am very sure that COVID virus is not going to change its behavior. Mutations will continue to emerge, but we must change ours and prevent the severe third wave from happening. Very, very sincere thanks to the entire country, the team of healthcare workers who are engaged tirelessly in saving the lives of the people of the nation, and they are the real heroes, and trying to do the best they can in very, very taxing circumstances. I thank my own team at the hospital and my entire colleagues at the CEREBRAL hospital for being a part of our effort at saving lives in this COVID pandemic. And with that, thank you all for a patient hearing.
Thank you, sir.
Thank you, Nilesh.
So, Ajay sir, there are a lot of questions. There are a lot of questions around antibodies.
Okay.
When to measure? We will take the question at the end, but I just want to take.
Yeah, I think we'll take the question on the end as we had planned earlier. I think I'll stop my screen share, and the space is yours, Raman sir.
Okay, Raman sir. So we initially had this Black Death plague initially, but in this pandemic, the biggest Black Death is mucormycosis. People are scared of it, really scared. Like people are scared of plague earlier, now they're scared of mucormycosis. So, and it's a unique feature for India, I believe. It's not seen anywhere else around the world. This fungal infections because of COVID or post-COVID treatment or whatever, it's seen only in India. So please shed light on how do we manage this particular infection, which is very unique to India. Please, sir.
Good evening. Thanks to Practo India. Thanks to Nilesh, my good friend, for giving us this opportunity. And Ajay, it's great sharing the platform with you. Having said that, warm welcome to the audience, wherever you are. And thanks to technology, we get connected even during these difficult times. And so follows the exchange of information. As Mark Twain had said, he said that I didn't let schooling interfere with my education. It's after leaving school or after leaving medical college that we learn. And we learn from efforts like this, organized by Practo and organized by Nilesh, where we exchange ideas, experiences, so that we can take care of our patients much better. So today's talk is going to be for the next 20 minutes on the management of COVID-19 associated fungal infections. When we thought we were just recovering from the first wave and we were complacent, as Dr. Ajay had mentioned, and we were very happy that we had won the war, and it was even officially stated that it's the end game of the COVID-19. Then came the second wave, and that was not the end. Along with the second wave came the COVID-19 associated fungal infection. And we were not prepared for the second wave, the intensity of the second wave, nor were we prepared for the what was going to happen subsequently. Just when patients were treated by the medical staff and then they were going home happy that they were relieved of COVID, another disaster struck. They had something very innocuous, probably a little nasal obstruction and stuff like that, and little facial pain, and they thought it was probably part of the COVID syndrome. And then finally, of course, we realized that it was a major problem of a fungal infection. And what is this? Which are those cases you can define as post-COVID fungal infections? There should be histological confirmation of the fungal infection, the biopsied specimen, and there should be positive evidence of RT-PCR for COVID-19, and the interval between these two should not be more than 3 months. Then it is related to COVID. Now, what is this fungal infection? This fungal infection is mucormycosis, an angio-invasive fungus which grows inexorably and invades tissue after tissue through the blood vessels. So what are the various types? We have the rhino, orbital, cerebral. That means it enters through the nose, goes to the orbit, and lands up in the brain. Then you can have rhino orbital, only the nose and the orbit involved. Or it could just be sinusitis, or it could cause a pneumonia, it could cause cutaneous manifestation, gastrointestinal, etc., etc. Those are the various forms. But what we're going to talk to you about today is rhino, orbital, cerebral mucormycosis. How does this come in? It comes through inhalation or ingestion or traumatic inoculation. Pathophysiology is initially there's angioinvasion, there's thrombosis of the vessels, and the tissue necrosis. And the tissue necrosis really makes it very difficult for the antifungals to reach the site. So again, that encourages the fungus to grow and invade nearby tissues. Now, what are the predisposing factors and site of infection? Diabetes for rhinocerebral, neutropenia for the pulmonary type, Steroids of any form, malnutrition causes usually gastrointestinal, trauma and catheterization, cutaneous forms, organ transplant cases, any of these forms can be seen. Now, as far as this presentation is concerned, now we have the orbit. What are the symptoms? They have eye pain, pain around the eye. They may have restricted movements of the eyeball. Then they can have watering of the eye, could be redness of the eye. It could lead to ptosis. It could lead to eyelid edema, cellulitis, and then bulging of the eyeball, which makes the eyeball more prominent on one side as opposed to the other. As far as the nose and sinus is concerned, we have nasal thrusting, nasal discharge, nasal block, pain around the nose, nasal bleeding, discoloration of the mucosa inside the nose, facial pain, and facial edema. Dental pain, loosening of the teeth, discoloration and discharge in the oral cavity also may be there. Now, as far as the cerebral involvement is concerned, you can have a neurological presentation. It has a wide spectrum, depending on what actually is being invaded by the fungus. It could be cavernous sinus thrombosis, cranial nerve palsies, visual loss, frontal lobe abscesses, arterial and venous thrombosis. So the spread of infection is from the nose, the nasal cavity palate, and to the orbit, and then intracranial, or it could even go to the pulmonary sites. So what is this that is causing this problem? When uncontrolled diabetes and severe COVID converge, the perfect storm is for mucormycosis. This is a recently published article. We all know that something is making these people much more susceptible to mucormycosis. In the pre-COVID era, I used to see 2 or 3 cases in renal transplant patients or uncontrolled diabetics with ketoacidosis. Now we've seen so many cases, and the total count as on today in India is almost, as on 28, is almost 9,000 cases and growing. And this is going to continue for some time, even after the second wave abates, because this comes after interval following the recovery from COVID. So the number of factors which cause this problem, and we still do not know what is the cause. Now, what is the radiological examination? You can do a CT scan for the orbit, paranasal sinuses, the brain, the lungs, depending on where this site of infection is. MRI scan, gadolinium enhanced, also can be very useful to see the spread of the disease. And the workup, of course, nasal examination, oral examination, ophthalmic examination, and then neurological examination. All these things have to be done. A swab can be taken as an outpatient for KOH, but it's highly unreliable. But if you get a positive swab, then it gives you a hint about the diagnosis. Tissue biopsy will be the main factor. You can do a CBC for neutropenia and do a blood gas for acidosis and check out on the sugar levels. Now, as far as the endoscopic examination is concerned, on the far left, you can see fungus in the frontal sinus. This is the opening of the frontal sinus as seen through the endoscope. And then here we have this opening which has been made into the maxillary sinus, and this blackish, grayish char, S-char it's called, and also here inside the maxillary sinus. And this is the infraorbital nerve, which has been invaded by the fungus. Now, what we have here is the palatal involvement. On the left side, you find discoloration of the palate. This is the floor of the maxillary sinus. So you can inject this area and give it away with it. But if it is worse, you may have to, like this, where the necrosis of the palate has taken place, you have to debride or even remove the palate. So that is the extent of surgical procedures that need to be done, sometimes even landing up in orbital excentricity. Now, it requires a multidisciplinary team approach to manage these cases. You need an otolaryngologist, you need a physician, you need a nephrologist, you need an ophthalmologist, an infectious disease specialist, plastic surgeon, orofacial maxillary surgeons, neurologists, and neurosurgeons. Again, the question which Nilesh asked in the beginning, why us, why India, is we have a very large population of diabetics, and maybe even a larger population of pre-diabetics or people who would become diabetic under certain conditions. So what has happened is, apart from the fact that COVID can attack the beta cells in the pancreas, we already have a large base of diabetics. And some of these diabetics do not know they are diabetics, and some of them are pre-diabetics. So we have a large population here, which makes them susceptible to mucor infection. Otherwise, mucor is everywhere, in the dust, in the manure, in the decaying areas, but it doesn't affect us because our immunity is good. So it's lack of immunity of the nasal mucosa, especially in rhino-orbital cerebral mucormycosis, which makes the person susceptible. And once this organism enters the respiratory passage, upper respiratory passage, that is the nose, the sinuses, etc., it goes through the blood vessels and spreads inexorably, destroying tissue and making many of these areas avascular. So even if you give antifungal treatments and the blood supply is lacking, you need to remove the eschar, the black eschar which is there, and save the various parts of the face. And unfortunately is on the facial area. So any of the radical surgeries could be very debilitating and disfiguring. But thankfully, these days we have endoscopic methods to do these things, so the disfiguring is less. But you need to see these cases fairly early, stay ahead of the disease. Now, the problem is, how often do you go and debride the tissue? Now, in cancer, you have safety margins, so you leave behind, and then you get it authenticated, making sure that you've removed the entire tumor. Here, you can't see those areas where the lesion is likely to spread. So, and you can't debilitate the patient by removing too much of tissue. So that is the difficulty in diagnosis and treating these patients. And one round of debridement may not be enough. So all three things should go simultaneously. Reversal of the immunocompetence, make the patient immunocompetent. Secondly, you need to give the antifungals and also do debridement so that the load on the antifungals is less and the patient improves. So the management line, as I outlined earlier, is hyperglycemia control, reversal of the immunocompromised state, extensive surgical debridement, antifungal medication, adequate doses, right duration, and reevaluation with endoscopy and timely follow-up. Now, what's happening about the antifungal medication? There's another man-made problem. Nobody imagined that the number of COVID mucormycosis cases is going to go up in such an astronomical rate. So what happened was there was no supply of the main drug, which is called amphotericin. So when the supply is not there, only two arms of the treatment you could control. You could only control hyperglycemia and you could do the surgical debridement. The third arm of this very important treatment was missing. So what happens? The disease becomes prolonged, more patients succumb, the disease becomes more extensive. So these were the problems we were facing. And apart from that, the affordability and cost. You see, the families have just recovered from a COVID infection, and thanking God for that. And soon after that, they have already, they've lost the battle. They've won the war, but lost another battle soon after that. So that is what is happening. And they're low on morale. They don't have enough money to, and the other resources needed to combat the disease. And you have a drug which is not available. And even if the drug is available, you're not able to afford it. And endpoint is not clear. So again, continuing with the management, the medical management of antifungals is usually amphotericin B, and the version with which you can give higher doses is the liposomal amphotericin. Even if the regular amphotericin is there, it has to be given in lower doses, continuously watch kidney function. Many of these diabetics already have a kidney problem, so you need to look at the creatinine levels. Then the other alternative drug is posaconazole, which was used earlier as a salvage treatment where amphotericin wouldn't work, but now it's being promoted as almost a first-line drug when you don't have amphotericin B, but it's not as good as amphotericin. Then we have isavuconazole, which is the other drug which has been given. These two drugs can also be given oral. That's the advantage. Now, surgical treatment is you have to take them under GA, and extensive debridement has to be done, and intralesional antifungals can be given, and that's at least they don't have the toxicity, and then regular endoscopic clearance and douching. All this involves multiple visits to the theater, multiple anesthesias, and multiple bill payments. Now, what are the outcomes? Multiple surgical interventions, long duration of medical management, regular blood parameters have to be monitored, radiological follow-ups have to be there, and according to literature, the mortality could be as high as 50%, which is really devastating. You've survived the COVID and you lose your life afterwards to mucormycosis. So to conclude, the COVID infection with diabetes and fungal infection should be kept in mind. Prompt evaluation of post-COVID patients with diabetes or immunocompromised state is to be taken. Timely and aggressive medical and surgical management has to be done, regular follow-ups have to be done, and there should be reversal of underlying pathology. One question which Nilesh asked me at the beginning remains unanswered. Why India? One, of course, I mentioned earlier, is because of the large number of diabetics, but are there other factors? Many people have blamed the oxygen and the humidifier which is used where the water is not pure, industrial oxygen which has been used, we're not sure. People who supply oxygen say the industrial oxygen is as pure as medical oxygen. Now, the other thing is the Delta variant causing more problems in India? We do not know. The numbers, earlier we used to have lesser cases in the first wave. In the second wave, definitely it is more. Is it just because of sheer numbers? Or is it because the Delta variant really causes much more, plays much more with the glycemic levels in the blood? We do not know. So there are a number of unanswered questions here. But one very important thing is what Dr. Ajihanda also mentioned. The WhatsApp sending of prescriptions can be very, very useful. It can shorten the distance between the treated and the treater. But it can also be transferred. In India, what happens is that we don't have any kind of intellectual property rights for a doctor's prescription. So the same prescription used from mother to father to brother to cousin, sister. So what happens is inappropriate treatment. We have definitely, whatever you might say, misused steroids. But why did we misuse steroids? Because that was the only drug which had one hope of saving a patient. So in our overzealousness to protect the patient and save a life, we might have used a little more. That is physicians. That would have been X%. But this 200% is because of self-prescription, inappropriate use of drugs by patients, and definitely I think the government should come down very heavily and make sure that steroids are not given out over the counter. So these are the measures that the administrators can take. Apart from that, programs like yours and the media, which is sometimes creates panic, doesn't matter. Let Indians panic, at least we'll take care of ourselves. Every other day we find 4 or 5 patients who come to us saying that, are we having fungus? Doesn't matter. We reassure them and send them back. But at the same time, we need to get controls. We can't be like a herd mentality in our country. And that's the only way. Follow the rules like a herd, but don't behave like a herd. And I think the wise advice given by my previous speaker, Dr. Ajay, has to be, we should enforce, as a medical community, we must ensure that the administrators take appropriate steps. And the main duty or important work that we as citizens should do is comply with the advice at that particular moment. Having said that, the knowledge of COVID is changing day by day. It's still work in progress. And let us hope the magic panacea arrives very soon. With that, thank you very much for your patient listening.
Thank you, sir. Thank you. Sir, if you could stop sharing your screen, we can see the questions and do that. Okay. Dr. Ajay, sir, we have a lot of questions around antibodies testing. So is it compulsory to check your antibodies after you have an infection or after you get your vaccine? And is it possible that you don't develop antibodies at all after infection or a vaccine? Is it possible?
So antibody formation after natural infection and antibody formation after vaccination are normal response to the vaccination. The antibody is definitely going to be there. It is formed as a normal immune response of the body, but it is not required to be tested. It only gives you a fear. Following vaccination, there were some figures quoted that antibody level should be so much, but there is no authentic medical data to support that antibody level has to be there, because there are 2 arms of the immune system. One is the antibody mediated arm and the cell mediated arm. So the vaccine stimulates the antibody formation as well as stimulates the T cells to recognize that this is how the virus is going to look. And when the infection happens, the vaccine stimulated or vaccine primed cells will go there and try to engulf and kill the virus, and the antibodies will do their job, and antibody mediated control will also happen. So following an infection, the immunity or the antibody formation is there, but it is not supposed to last very long. it is expected to cover a period varying from 6 to 9 months following that infection with that particular strain. Now that the strain is totally different, there is no protection or minimal protection if there is any. So vaccination is required, and antibody testing is not required. Don't bother if antibody is formed or not formed. If it was a very mild infection, antibody formation may not be happening to the tune where the antibody forms in a patient with a moderate to severe infection. But nowhere it is recommended for using the antibody titers to say that now you are safe, because COVID has mutants and they are more infectious. So the three things which remain are mask, distancing, and hand hygiene, and vaccination.
Yeah, thank you, sir. Because I see a lot of my colleagues, they jump into testing antibodies within 2 weeks of being positive. I mean, it gives them a high to see if antibodies have been formed. But it is not necessary. You're just putting extra stress on yourself. So
Correct.
Another question.
So if antibody is not, yeah, sorry.
Yeah, please.
So if antibody is not formed, it does not mean that there is no immunity, and definitely the phenomenon, and it does not require a laboratory. And what is the antibody that you are testing? The neutralizing antibody titer is important, and it is not recommended except in research centers where they are making publications and all those things for vaccine trials. It is not recommended for clinical practice.
Right. So another question for you again. I know you have already spoken on this, how to manage a cytokine storm and cytokine inflammation. But Philippi, there was a specific question. Is there something we can do to stop or avoid cytokine inflammation at all? Is there something we can actually do?
Okay. So cytokine mediated inflammation mainly affecting the lungs, causing COVID pneumonia and ARDS. The drug of choice for the treatment is a steroid. The only thing is, in which patient should it be given? It should not be given for a person who is having a mild COVID. Just a cough, cold, sore throat, stuffy nose, body ache is not required to be given the steroid. So I had mentioned very clearly, early phase of hypoxemia. So that means the person is checking his oxygen level. It was 98, 99. Now it has come into the range of 93, 94, 92, whatever it is. So the person has to have a physician prescribed steroid on the premise that the person is now entering into the early hypoxemia phase, or whenever the person reaches the hospital with breathlessness, whatever the level, if he is requiring oxygen supplementation, they are given corticosteroids in regulated doses with clinical monitoring of the patient's response, as well as the other parameters, which includes glucose monitoring as a side effect of steroid therapy. And if it is found that COVID or steroid is contributing to hyperglycemia in the range of 200 plus, the person is given insulin to keep the sugars which are in the safe range, that is 120 to 180. That is the range we would like to keep it, not the patient being unregulated hyperglycemia with use of over-the-counter corticosteroids at home, as Dr. Raman was mentioning, is the biggest cause of concern of the medical fraternity, given the fact that we are seeing much more cases of fungal infections, specifically mucormycosis. This strain definitely causes increased incidence of mucormycosis due to more than one reason, and all the reasons were beautifully covered by Dr.
Right. Dr. Raman, which brings me to a question for you. You mentioned steroids and a lot of other causes, diabetes and other.
So cytokine treatment, corticosteroid, and I mentioned that if the person is progressing.
Right. So I'll take this forward. Dr. Raman sir, you mentioned about steroids and diabetes and other features which might predispose to mucormycosis. There was one very famous theory in the media, at least, about the use of oxygen masks and oxygen humidifiers causing mucormycosis. So how true is that?
I do not know. Maybe a number of factors are there, but I think that will come lower down in the list, if at all. because, I mean, I shouldn't be saying that, because we Indians are used to some amount of not absolutely high standards of sanitation. We should have seen all these things in our patients earlier also, in some form or the other, not in this large form. Maybe it's a factor, but I think it will come lower down in the line.
Right, sir. One more question for you, Raman sir. So you mentioned that the criteria for diagnosis of COVID-associated mucormycosis is within 2 months of the infection. So,
Within 3 months.
3 months, I'm sorry, 3 months. So is there any particular time period where we can mostly expect mucormycosis to come up? 2 weeks, 3 weeks? And second question related to that is, what could be the first symptom? Pain around eyes, movement, what could be the things to watch out for mucormycosis?
Extremely good question in terms of early management of mucormycosis. 3 months is the date, but most of the cases come around 30 days. But there are cases which I've seen in our own series, they've come as early as 7 days. So it was initially thought it was much later, but you have cases which have come as soon as after 7 days. And roughly 30 days plus minus 10 days is the average. Now, a person who was to look out for any of these symptoms would be nasal obstruction, nasal crust formation, lack of sensation around the face, because these patients, when you even do a work inside his nose, you find that they don't require an anesthesia because they're not feeling your instruments. So one of the earliest signs is hypoaesthesia. They can't feel, I mean, the loss of sensation. These are the early symptoms. But there are some symptoms where it progresses and they get undefined headaches around the sinus area, and especially around the eyes. And if it progresses more, of course, the other ophthalmic symptoms come, but that's little advanced. So people can get themselves checked much before that. Other thing is that related to the teeth. When a tooth starts paining or gets loosened, people don't relate it with mucor, but the floor of the maxilla, the maxillary sinus is the roof of the mouth. So that's another area it can start. Depends on which way the spread is occurring, but it always starts from the nose. So any nasal symptom you have, unless you've been having a lot of allergic, sometimes it becomes difficult when a patient has had a pre-existing sinusitis, whether the new symptoms that are there is old sinusitis presenting, or is it mucor itself. So unfortunately or fortunately, you have to go to the doctor, and who has a look and does a KOH specimen in the OPD, and then take it from that. Okay.
Right, sir. Right, sir. Ajay sir, there's a question for you. So this long COVID is a big issue now. So people are quite scared of long COVID because there are news around it can give rise to new diabetes, hypercholesterolemia, heart disease, which were not present earlier. So is there a way to identify the long COVID syndrome as early as possible, and what can be done to avoid that? Dr. Ajay, can you hear me?
So predominantly, the question initial part was not clear.
Yes, sir. If I may repeat, the question was around long COVID. What to expect and how to avoid?
Yeah. COVID is can systems, predominantly nervous system. So respiratory symptomatology is in the form of breathing difficulty, cough, chest pain, chest tightness, and the neurological symptoms will be in the form of headache, tiredness, post-COVID fatigue syndrome, and tingling in the feet, feeling weakness in the limbs, and these symptoms, and sometimes memory impairment. Some patients may even go into frank depression and sleep issues like insomnia. So it is seen in people who are older and who are generally more common in ladies. So I encourage people to be positive in terms of their mental outlook, following recovery from COVID, and get them into some form of physical rehabilitation, pulmonary rehabilitation, so that they're exercising their limbs and the breathing exercises, yoga, meditation, relaxation, along with the medication. So pulmonary and physical rehabilitation plays a role in early recovery from long COVID, especially the persons who have post-COVID lung inflammation and lung fibrosis, and of course the other neurological symptoms which I mentioned. So that's the way that you're positive in your outlook, and do the medications as prescribed by your treating physician, and also do some physical activities under medical supervision. So long as you don't have any significant cardiac issues, you can gradually restart your activities. The activities should not be strenuous in nature for the first 4 to 6 weeks.
Got you, sir. Raman sir, steam inhalation has been a very popular treatment or preventive medicine in India. What are your thoughts on that steam inhalation?
See, somebody has made that the chief villain. I think that's out of place. Like I said, there are multiple factors, and when you don't know, you're wondering. Like this guy, the United States Secretary of State, was asked, "Where is Osama bin Laden hiding?" And he said there are 3 types of knowns: the things that you know, things you do not know, and things you do not know, you do not know. So that's the state we are in now. We have suspects. So to say that steaming alone causes, no, there has to be something more than that. Mucociliary movement is important. Steam is one of those more benign ways of creating moisture, but anything that is overdone is not good. I'm told that there are patients who come with burns on their faces because of constant steaming, because somebody said you keep doing that. So that's the extreme. But is that the sole cause? Definitely not.
Right, sir. Right. So do you suggest that people can continue with steam inhalation, at least for the preventive part of it, maybe once or twice a day? Would it help?
I think it's not a bad idea, because I feel that some kind of humidification always helps. The cilia are not able to move the sol and gel layer. It moves that. If there is enough humidification, and humidification is always helps. I believe that anything that done within certain limits should be fine. That's not the panacea for any illness, but then it makes you feel much more comfortable. Mucosal clearance improves. And once mucosal clearance improves, stagnation is less. If stagnation is less, whatever organism that is there stays there for a shorter period of time and can't really multiply and create problems for you.
Right, sir. Right. Got you, sir. So suggested is that you might continue with steam. We really do not know if it helps or not, but you might as well, but don't overdo it.
Yeah, I'm aware of the fact that some of our doctors have said don't steam. I don't go to that extent.
Right. Dr. Ajay sir, one question for you. There are some doctors saying that D-dimers might not go down to normal even after 1 month of recovery from COVID. So is that an important parameter to look at, and does it signify anything?
Yeah, so post-COVID D-dimer values sometimes take almost 2 months to 3 months to normalize. But this is more important for those patients who had been in hospital and had a clinical severe COVID disease, moderate to severe COVID disease. If a person had a mild COVID disease, then he need not actually keep following his D-dimer values unless he has other risk factors for coronary artery disease like diabetes, hypertension, cigarette smoking, obesity, etc. So there is an increased chance of this indicating that there is a slightly increased tendency for development of thrombosis, but most medical literature does not recommend using D-dimer serial testing in the post-COVID follow-up. It would be useful for testing patients who have had a clinical evidence in the form of a pulmonary thromboembolism or a deep vein thrombosis, or in fact, for that matter, a cerebral venous thrombosis or any other systemic venous thrombosis, to monitor the D-dimer level. Otherwise, it would be alarming to see an elevated D-dimer level, and again, like the antibody, would be causing more anxiety and stress and lack of sleep, which is more harmful than just following your doctor's advice.
Right, sir. Right. So there is one question which has been asked about nintedanib. So how effective is it in treating pulmonary fibrosis? I really have no idea. If you could shed some light on this.
Oh, no issue, no issue. This is an antifibrotic molecule. It is called nintedanib. It is an multi-tyrosine kinase inhibitor. Epidermal growth factor, platelet-derived growth factor, and transforming growth factor are blocked by this molecule. It is useful in the treatment of idiopathic pulmonary fibrosis, a common cause of interstitial lung disease, and connective tissue disease related interstitial lung disease. Now, since COVID causes a lot of fibrosis, there are two molecules. One is nintedanib and the other one is pirfenidone. Both have been used by physicians across the country in those patients who remain hypoxic with significant post-COVID pulmonary fibrotic changes and hypoxemia, to minimize the fibrosis from becoming more dense and causing irreversible fibrosis. Now, the only word of caution about nintedanib is that it is a vascular endothelial growth factor also gets inhibited. This is the fourth this part of the action. So it has a tendency for bleeding both from mucosal surfaces and inside the intracranial cavity. So almost all patients of severe COVID are getting antithrombotic medication like low molecular weight heparin, heparin, and they are likely to have a higher chance of bleeding. So I definitely would recommend, if an antifibrotic is to be used under the prescription, it is better to use the other molecule, that is pirfenidone. But if it is used under the prescription of a pulmonologist / a physician, nintedanib with close clinical monitoring has been used by various physicians. It's a personal recommendation that I prefer pirfenidone because it has got no risk of bleeding.
Excellent, sir. Because that was my second question about pirfenidone. Somebody had asked which is better, and you already answered that. There are a few other minor questions which you have already answered in your previous questions or in your presentations. So I won't really take those up now. Some last words, sir, about how we can prepare for the third wave. Should we be scared? What do you expect?
Just some last
answers. Dr. Raman, sir, please.
Yeah. This is a question to Ajay. Ajay, you think this monoclonal antibodies might be the game changer, at least for some patients in the third wave, in case as and when we get it? Cocktail.
Sir, yes, sir. So the monoclonal cocktail is a molecule which is useful for preventing the mild COVID going on to a clinical severe COVID in those patients who have severe comorbid conditions which are known to cause a severe COVID adverse outcome. Say a patient has got a leukemia or a transplant recipient develops a mild COVID. That will be the ideal candidate if he is proven COVID and having minimal symptoms in the form of cough, cold, sore throat. You would like to give it to him so that the illness is terminated. Again, its efficacy is about 70%. So some of them will, despite the use of monoclonal, may go on to developing a clinical disease, but definitely it mops up the virus, so the viral load will be down. It may not cause a respiratory failure type of situation. So in our clinical practice, we haven't yet started using, but across Bangalore city, we have had experiences from other physicians who have started using it in elderly, those who have diabetes, those who have obesity, severe underlying lung disease, cirrhotic patients, kidney failure patients, transplant recipient patients, anybody of this nature with early COVID, that is a day 3 to day 10 is the window of the illness. So if you know your first day of onset of symptom and you have a positive report, you could consult your physician for whether you are a candidate for the monoclonal antibody. Anybody who is having a symptomatic COVID with oxygen requirement is not a candidate for the monoclonal therapy.
Right. I'm slightly greedy, so I just take one question each again, sir. Just one question each. Dr. Raman, sir,
yeah, sure.
I was diagnosed with COVID, came back home perfectly fine. I have some pain around my eye. I think I might have mucormycosis. What is the screening test should I go for? Is there a screening test which is?
You have to go and meet the doctor. Clinical history will give him some hints. Secondly, he could examine your nose and even do a nasal endoscopy. Like I told you, if the nose is insensitive without local anesthesia, that itself gives a hint of impending COVID or COVID which has started off. Then, of course, he can also look at those areas which are not normally seen with just a headlight and inspection of the nose. He can have a look at the opening of the sinuses near the middle meatus, whether there's any black eschar or not, and then do a KOH swab test, which you'll get in 24 hours. If that shows any fungus, which could be mucor, then you're on the alert. Otherwise, just meet your doctor in case he wants you to see you again after a week, because we don't want to be behind the disease. We want to be ahead of the disease. 2-3 visits to the doctor, but it will save you a lot of trouble.
Right, sir. On the same line, one last question to Dr. Ajay. Sir, post-COVID lung fibrosis is something which scares a lot of people. I think possibly the most commonest long COVID syndrome sign. So what will be the common symptoms of lung fibrosis? I think it's easy, but could you answer that and the screening test for that?
Okay. So anybody who has post-COVID breathlessness and cough and low oxygen saturation, that is, he is having, despite the completion of treatment, he has oxygen saturation which is in the range of beyond 97-96%. Or if he has a breathlessness and oxygen saturation which was 96-97 has dropped to 88-86, that is an indication that he is having a ongoing lung problem. And the screening test is, if he hasn't undergone imaging, we would like to do a high resolution CT, but most of the patients who are hospitalized have already undergone one high resolution CT scan. So exposing them again so soon is not required. So what we do is we treat these patients with medications for about 2 to 3 months and then follow them clinically. Most of them are able to come back to normal oxygen levels. If they were discharged on oxygen, they are now breathing normal air and maintaining their oxygen levels. These are indicators that the underlying lung fibrosis has improved, because irresponsible use of CT scan can lead to lots of radiations. Many patients have got 2 scans, 3 scans done in the fear that they are having post-COVID fibrosis. It will do only harm.
Right, sir. I think we have taken up all the questions, and Dr. Raman sir, I know you have a next engagement coming up at 6 o'clock. So I will let you guys go. Thank you, Dr. Ajay. Thank you, Dr. Raman sir. It's been a great pleasure having you. Thank you to all the audience for being there and watching this webinar. Thank you, sir. Have a good day ahead.
Thank you.
Thank you, Nilesh. This was a great experience for me too.
Thank you, sir.
Thank you.
Thank you.
It's a learning experience every
Bye,
time.
sir.
Right,
Bye-bye.
sir.
Bye.
Bye.